Good afternoon to all the dignitaries and all the doctors attending the session. I would like to welcome all the dignitaries and all the doctors for the second session of our scientific by the College of GP IMA GSB in association with the College of GP. First of all, I would like to invite Dr. Anbur Rajan, who is the Honorary Secretary of IMA, the CGP headquarters. Before that, I would like to introduce him. Dr. Anbur Rajan, he has done his MBBS in 1989 from Madurai, but from that he has continued his academic activity throughout his life. He has done DMLS from Pune in 2000 and DFCW from National Institute of Health and Family Welfare in 2004, FHM from Vellore in 2008, DFM and FCGP from IMS CGP in 2009 and 2010. He is doing his family practice since 1991. He is attached with so multiple organizations, has different positions like director, trustee, managing director, and the project director also. He is also president of DO Fevenet Art Institute for Girls and Orphanage. He is the state coordinator of IMA and TB initiative and the secretary of NHB IMA TNSB. He has remained past president of IMA Tirunelveli and the past vice president of IMA TNSB. He has also worked as a past secretary and director of IMA TNSB CGP. He was also national assistant secretary and joint secretary of IMA the CGB headquarters. He has attended so many world Christian doctor network meetings in abroad in so many countries. He has also published so many publications. He was awarded by so many times like Rashtriya Ekta National Awards for Community Harmony, and he has also awarded as a COVID warrior award. He has also Tamil Nadu Medical Community Award for COVID-19 also. So we are so happy to see him as a really legendary person with us, and we are so lucky for that. So with short introduction, I would like to invite Dr. Anbur Rajan. Please, sir.
Yes, sir. Thank you, Dr. Dhiren, for your kind introduction. I have to congratulate the College of General Practitioners, IMA Gujarat State Branch, in a very, wide way that this kind of program that you are conducting, that was the second month program that I was very fortunate to be with you in this program. It's a very much needed program for our fellow doctors. As such, IMA CGP was started in the year 1963, and its main aim is to encourage and foster and maintain the highest possible standard in general medical practice, and to maintain academic and educational institutions, to establish the college as a deemed university, and to encourage our members to undergo various trainings and courses which have been made to increase their skill in general practice. We are publishing a family doctor journal every month, and we want to take the concept of family medicine to all the doctors, especially the young doctors. So we want to improve the knowledge of our primary care physicians in various disciplines like diabetology, cardiology, family medicine, and today it is on respiratory medicine. So likewise, we are already conducting a fellowship in family medicine program and also fellowship in primary care echocardiography, to improve the knowledge of our general practitioners when they get cardiac cases, what to do, they have to decide immediately in the prime time. So likewise, we are planning to have programs on diabetology, infectious disease and infection control, sexual medicine, psychiatry, hospital administration, geriatric care, respiratory medicine, and toxicology. So we are routinely having every year 4 zonal meetings, North, East, West, and South. The West zonal meeting will be having in, maybe we will be having in Mumbai, and the South Zonal meeting will be having in Karnataka state. And every year we'll be having a GP Con. This year, as it is going to happen every year, this will be happening in the place of our Dean. You know, last month, our Dean, Dr. Ayapur Ramesh Babu sir, has attended this program. And this year, we'll be having that in Tirupati in Karnataka state, Andhra Pradesh. So, we are also conducting every month a CME program on particular topic, morning to evening, on the last Sunday of every month. We encourage our state faculties to conduct statewide conferences. And this, we are conducting fellowship in general practitioners course, FCGP, for those who are practicing less than 20 years. And for those who are practicing more than 20 years, we give them honorary FCGP. You all can get this details from our website and our e-journal. So that will be sent to our state leaders. In turn, the state leaders are requested to send them to your, all members. So you can become the member of CGP. It is a call to all the general practitioners by paying 295 rupees, including their GST, as a life, membership. And for even the other specialty, people can also become the members of this by paying 1,180. So you can become the member of CGP and get all the benefits that CGP is giving through the headquarters office. Now today's topic is regarding respiratory diseases that we come across in our general practice. Simplified approach to asthma management. Maybe 20% of the cases what we get in the general practice will be of respiratory diseases. And in seasonal time, in monsoon time, we'll be getting nearly 80% of the cases of respiratory infections. In that, those who are having asthma will have aggravated during this time. And then it is better to give them a proper management that we are going to hear from Dr. Harjit Dumra. And optimizing that delivery is a device that through which will be achieving a proper, response in obstructive airway diseases. Dr. Tushar Patel is going to enumerate on this. So we are very lucky to have both these speakers to enumerate these things to us in a very effective way. I congratulate the Gujarat State branch of IMA and also the CGP faculty of Gujarat State branch. Very success of the continuous program what they are going to do this. And I also congratulate those who are joined today to get more knowledge and to be successful in your practice. The knowledge you are getting from the experienced persons will be definitely being transferred in a good way to your patients, and then you will be getting benefited out of it. May God bless you all and keep you peaceful and safe in your practice, and let your practice be fresh as you get more knowledge. Thank you very much for the opportunity given to me. God bless you all.
Thank you, Dr. Anburajan, for giving the brief introduction and the information regarding the College of GP, and also giving some ideas to diverse our practice, family practice, routine family practice. Actually, today we also have discussed regarding the joint courses or the CME programs in FFPI also. So we can arrange some certificate courses for our doctors, so they can do some different sort of practice just out of box of the routine practice. Okay. Thank you so much, sir.
Thank you.
Now I would like to invite Dr. Vinod Bhai Shah to carry the program further. Thank you, sir. Dr. Vinod Bhai.
Good evening, friends. Dean IMA College of General Practice, Dr. Ramesh Babu, Honorary Secretary Dr. Ambu Rajan, President IMA Gujarat State Branch Mahavir C, Honorary Secretary Mehul Bhai, Director College of General Practitioner IMA State Branch, our dear Dr. Jaswant, and today esteemed speaker Dr. Harjit Dumra and Dr. Tushar Patel. On behalf of College of General Practitioner IMA GSB State Branch, Dr. Vinod sir, very happy to welcome you in very important lecture series for family physician on asthma management and obstructive airway diseases. We have with us very learned faculties on this interesting respiratory topic. Before presenting Dr. Dumra, I would like to introduce in short. He is Dr. Harjit Dumra, MD Internal Medicine, is working as consultant transplant pulmonologist, sleep medicine, and critical care specialist at KD Hospital, Ahmedabad. He is a director at Sparsh Chest Diseases Center. He was trained in pulmonology and critical care medical from KEM Hospital, Mumbai, and did his observership at Cleveland, Ohio, in USA. He is honorary pulmonologist and critical care consultant to His Excellency, the Governor of Gujarat. He is a teacher for DNB Critical Care and teacher for Indian Society for Critical Care Medicine Fellowship Program. His area of interest are critical care, pulmonary hypertension, interstitial lung disease, a very complicated and complex topic, a lung transplant, interventional pulmonology, infectious diseases of chest. He has published a number of papers in the Index Medical Journal, and he wrote chapters in the textbooks of pulmonary and critical care medicine. With this very, very short introduction, I request Dr. Dumra to start his topic, very important for family physician, a simplified approach to asthma management. Dr. Dumra, please.
Thank you, sir, for those kind words of introduction. I'll just load my slides. I hope my slides are visible.
Yes, sir, slide is there, visible, it is visible.
Fine. So, like Dr. Anburajan just mentioned, asthma is a very common disease which most of you encounter in your day-to-day practice, and hence managing this disease should be, in fact, a priority for most general practitioners. So I'm very happy that you brought out this topic for discussion today. Unlike a lot of other diseases, I think literature has grown for managing each and every disease, but as things have evolved, guidelines have become more complicated and complex and not easy for each and every one of us to implement in day-to-day practice. Unlikely, this is not the case with asthma. In fact, with passage of time, asthma management and guidelines for asthma are being simplified. And hence, today, even a general practitioner can very well practice very effective asthma management because now asthma management is no longer complex. So over the next 20 minutes, I'm going to allude to this simplified approach to asthma management. And hopefully at the end of the session, most of you should be able to manage a lot of your patients much better than what you are doing today. And if there are any questions, you are most welcome to ask me after the end of the session. So just to set the ball rolling, I'll give you a brief context about the disease burden in our country. So India has huge volumes of asthma. In fact, basically around 35 million asthmatics across the country, and it accounts for around 13% of the asthma burden across the world. What is very important is we have a lot of asthma deaths in India, and this is surprising because asthma is such a beautifully treatable disorder that you don't expect patients to die because of asthma. But 13 of 1,000 deaths in our country are because of asthma. Not only that, a lot of morbidity has been attributed to asthma in India. And in fact, it accounts for almost 28% of disability adjusted life years, clearly showing that asthma carries a huge burden in day-to-day life in our country. In fact, India has 3 times higher mortality and more than 2 times higher disability adjusted life years compared to the rest of the world, which indicates that for some reason, management of asthma in our country has not been improving over the last couple of decades. Now, as all of you know, inhaled corticosteroids, the common ones, budesonide and fluticasone, with or without long-acting beta-2 agonist, these are formoterol and salmeterol, are the cornerstone of asthma management. Just to sort of clarify, inhaled steroids improve the underlying eosinophilic inflammation in asthma, which leads to reduction in symptoms, bronchial hyperresponsiveness, and all of that put together prevents exacerbation and asthma-related mortality. Now, in spite of knowing this as a fact for the last 20 years, we still face challenges in managing our patients. Partly, our patients are to be blamed for this because in our country, there is a lot of apprehension about using inhalers. There is fear of addiction of inhalers. People believe that inhalers are only to be used when there is a severe attack. Patients tend to prefer oral drugs. They believe that inhalers are expensive. There are multiple inhalers available, and hence this understanding of the role of medication in inhalers is not easy for patients. Sometimes patients have false expectations from their inhalers. They believe they will cure them, and when they are not cured, they believe the inhalers have not done their job. There is poor education of our asthmatic patients from us and from our colleagues, and people are apprehensive about the labeling of asthma itself. So someone, if you give a diagnosis of asthma to a patient, he considers it as taboo. Last but not the least, they believe that inhalers contain steroids, and they do not differentiate between oral or systemic steroids and inhaled steroids. Remember, inhaled steroids given in appropriate dosages for lifetime are not associated with any significant side effects, which is not the case with oral or systemic steroids, which have got considerable side effects. And hence, our patients are willing to take any highly toxic medication, but they are not willing to take inhalers. So part of the blame for lack of control is with the patient. But what is very important is that we as practicing physicians are also equally at fault. This was a simple study done at the National Chest Conference in our country, which included pulmonologists. And this was done very recently, around 7 years back. And the simple question which everyone was looking at was, do pulmonologists stick to guidelines when managing different respiratory conditions? And one of them was asthma. Surprisingly, even pulmonologists, and this was a 1,000 pulmonologist survey. So there were 1,000 pulmonologists who answered this questionnaire. And it was found that only 45% of pulmonologists used inhaled steroids in optimum dose for treatment of asthma. So it clearly indicates that even our colleagues, specialists who practice chest medicine, are not optimizing asthma management. So a lot of the blame is also on our shoulder. And because of this, the global burden of asthma in India is huge. In fact, even after diagnosis, less than 2.5% of asthmatics end up receiving inhaled steroids. And when undiagnosed, only 1% would end up using inhaled steroids, clearly showing that almost 97% of our patients, in fact, after diagnosis, do not get the proper medication. And this is the gap we need to fill up. And that is why CMEs like this are extremely important to improving asthma outcomes in our country. Now, with that brief introduction, I'll use a case vignette to help you to highlight some of the important aspects of asthma management as of 2023. So this is my patient. His name is Janak. He's 36 years old. He comes to me with recurrent sneezing, rhinorrhea, and that he's had since childhood. Now, last few years, his breathlessness has become increasingly difficult to manage, and he has episodic worsening 3 to 4 times a year. And over the last 6 months, this has worsened further. Now he has persistent cough and shortness of breath. He also notices wheezing when he exerts. And despite the fact that he is adherent to the prescription he's been given, he is reporting increasing cough. And this is particularly present at night. He has been given a diagnosis of asthma, and he's on oral sustained release theophylline and 5 milligrams of montelukast, and this has been prescribed by his physician. He's also on an Aerocort inhaler, which contains beclomethasone and salbutamol, which he uses as per need because his physician told him that you can use the inhaler as and when he feels breathless. Now, over the last 3 months, because his asthma is worsening, he has been using 2 daily doses of his inhaler. And recently, because he worsened, he was given a 5-day course of steroids, because that is the treatment which is prescribed commonly for acute exacerbation. There are other issues which are important in this patient. He is obese, his BMI is 32. He has been prescribed a spacer with the inhaler. You can see this at the right-hand top corner is how to use an inhaler with a spacer, but he hardly uses the spacer. He uses his inhaler directly. His father stays with him who smokes in his presence. He has a pet, he has a parrot. He has family history positive for seasonal allergies. And his known triggers of asthma are seasonal allergies, exercise, and viral illnesses. He also complains of heartburn and fullness of stomach, particularly after meals. And this also tends to worsen his asthma. Now, how all of that is relevant to management, I'll come over the next few minutes to those things. So the most important question here, which faces us when this patient comes to your OPD, and this is day-to-day patient of asthma, is how would you manage this patient? So first and foremost, when you look at any asthmatic, the first question you have to assess or ask yourself is my patient having controlled disease or uncontrolled disease? You have to assess control. So what do we mean by control? Control is the degree to which the symptoms of the disease, the manifestations of the disease are reduced or removed by therapy. So we commonly look at the symptoms. These are daytime symptoms and nighttime symptoms. We look at the limitation of exercise, which happens with these patients. Many of our patients cannot climb staircase. Many of our patients can't go out for long walks. Many of our patients, if they want to cycle or go for swimming, they are not able to perform those activities. We also look at the need for reliever and rescue medication use. Then we look at lung functions and the frequency of episodic worsening, which we call as acute exacerbations. And all of these are basically assessed to judge what is the level of control in any given patient. So if any patient has more than 3 features out of these 6, you label them as having uncontrolled asthma. So if they cannot exercise, if they have frequent nighttime awakenings, if they have excessive use of salbutamol, which is the reliever, if they have poor lung functions or they are frequently exacerbating, all this constitutes uncontrolled. For definition purpose, uncontrolled asthma includes poor symptom control and frequent exacerbations requiring oral steroids. So if you remember these two, even that would be sufficient for you to identify an uncontrolled asthmatic. So obviously, our patient has uncontrolled asthma. The second thing is, once you know this patient has got uncontrolled asthma, you obviously have to optimize his medication. So presently, our patient is taking beclomethasone salbutamol metered dose inhaler with sustained release theophylline, and he is on 5 milligrams of montelukast. So what changes do we need to do to improve his asthma? Now, traditionally, asthma management includes 2 different medications. On the right-hand side, which I have shown, is the controller or the maintenance medication. What do you mean by that? Controller medication or maintenance medication has to be taken every day in a fixed dose at a fixed time, regardless of whether the patient is symptomatic or not. It is a daily, lifelong therapy, whether it is inhaled corticosteroids or a combination of inhaled corticosteroids with a long-acting beta-2 agonist. This controller medication is very similar to what you would do for your patients of hypertension, diabetes. So you give them a fixed dose and ask them to take it religiously, regularly, even on the days when they are not symptomatic. And on top of that, if the patient does have symptoms, you can use a reliever, which is commonly a salbutamol, that is a short-acting beta-2 agonist. Now, traditionally, this has been taught that you have 2 inhalers. One is the controller one, which you take regularly, and the second is the reliever one, which you take on need basis. So in this long and huge list, don't go through all the drugs, but on the left-hand side is what we call relievers, which commonly is salbutamol. And on the right-hand side, you have the controllers, which are the inhaled corticosteroids. Now, what do the reliever do? It does bronchodilation. And what do the controllers do? They are anti-inflammatory drugs. That is, they improve the inflammation in the airway. Hence, controllers are to be taken regularly and relievers are taken occasionally, as in when the symptoms happen. Ideally, the patient should have no need for relievers. That would be an ideally controlled asthmatic. So the patient could be managed only with a single inhaler without requirement of reliever, but that is seldom seen. The commonest controller medication is usually a combination inhaler. We don't use inhaled steroids in isolation. So usually we combine them with long-acting beta-2 agonists. So the common two ones for your day-to-day use could be fluticasone with salmeterol or budesonide with formoterol. Now, why do we combine long-acting beta-2 agonists with inhaled steroids? We no longer use inhaled steroids in isolation because there is clear-cut data that if you increase the dose of inhaled steroids, there is a plateau of effect, which means increasing dose of inhaled steroids will not improve efficacy, but it will give rise to unwanted side effects. So the dose increases, but the effect plateaus off. But if you add long-acting beta-2 to an inhaled steroid, that effect is much better than increasing the dose of inhaled steroids. And hence, as of the last 10 years, we have been combining LABA with ICS as our main therapy for all patients of asthma. So this leads to improvement of FEV1, and that is basically symptom control, improvement of lung function, and it reduces exacerbation. Now, the effect of both these molecules, formoterol, budesonide, or salmeterol, fluticasone, is the same. So you can choose out of these whichever you want as a controller, and you will get similar benefits. But there are some subtle differences in both these molecules, and I want to highlight this because this is the basis for simplifying asthma control, which is the topic which we are going to discuss today. So out of these two molecules, salmeterol, the major issue is that the onset of action takes roughly around 15 to 30 minutes. So if you take it, it will take half an hour for your patient to improve. But with formoterol, the onset of action is within 1 minute, which means it is a rapid acting drug. It will give you immediate relief. Secondly, salmeterol has a fixed dose. You cannot go beyond 100 micrograms. So if your inhaler has one puff of 25 micrograms, you can go to a maximum of 2 puffs twice a day. You cannot exceed that because beyond that, there are toxic side effects with salmeterol, particularly like cardiac side effects. But with formoterol, you have a luxury of going up to 12 puffs a day in case you need to, without any problems, without any side effects. So formoterol for us becomes a rapid acting drug and a safer drug, which can be used multiple times a day without any side effects. So just to highlight that till now we were using salbutamol as the reliever. The difference between formoterol and salbutamol is the onset of action is equally fast with both products, but the duration of action of formoterol is much longer as compared to salbutamol, and that is why it makes formoterol a more attractive option to use as a reliever, because it will work as fast as salbutamol does, but it will have prolonged effect, unlike salbutamol, where you will have to take multiple dosages at short intervals. So, like I said, there is a confusion in most case scenarios with patients and with prescribers as to which inhaler to use when. Sometimes because of this, patients end up using relievers more than the controllers because relievers give them immediate relief, but controllers take time to act. And that is why asthma control is never established. So that is what the crux of the problem is. Multiple inhalers creating confusion in the minds of prescribers and patients. Now, besides that, there is also now sufficient data which says that if you use or abuse salbutamol excessively, it leads to increasing exacerbation, but it also leads to more asthma deaths. And this is directly proportional to the number of salbutamol inhalers you use per year. So if you are using one inhaler of salbutamol, which contains 200 dosages a month, there is a 3 times higher chance of mortality because you are not going to use the controller, and salbutamol in excess doses will lead to side effects. So remember, excessive use of salbutamol can cause death. So that is very important because most of us believe that when you use salbutamol inhaler, you can give as much as you want and this will not harm the patient. No, it will harm the patient. So this has been the traditional approach where you use a controller like salmeterol, fluticasone, or formoterol, budesonide, that is an ICS LABA, and you use a reliever like salbutamol. Now, over the last decade, we are changing to what is called the SMART approach. And what is the SMART approach? You use regular salmeterol, fluticasone, or formoterol, budesonide. That part remains the same. But instead of using salbutamol as the reliever, you use an ICS LABA as the reliever, that means the controller and the reliever become identical. Now remember, for this approach, you cannot use salmeterol fluticasone as the smart therapy. Why? Because salmeterol will have delayed onset of action and it cannot be used as a reliever. So for this approach to be practiced, any combination of inhaled steroid with formoterol will work. So you can use formoterol budesonide or formoterol beclomethasone or formoterol fluticasone or formoterol mometasone. But the most important part of this combination is formoterol because it has rapid onset of action and it has prolonged effect. And given with inhaled steroid, it will give you bronchodilatory and anti-inflammatory effects simultaneously as compared to salbutamol, which only gives you bronchodilatory effect. Now remember, most of our patients take extra inhalers, particularly when they are symptomatic. Other times they might not be compliant with the inhalers. And hence, whenever they are symptomatic, it would be ideal not only to increase the bronchodilators, but also control the inflammation, because without controlling the inflammation, this exacerbation will lead to worsening and eventually will lead to excessive use of systemic steroids, which we want to avoid. So to simplify what I'm saying, I'm going to show you this cartoon. So usually before an exacerbation, around 5 to 7 days, there will be warning signs. So the patient will have increasing cough, worsening breathlessness. And most of the times patients start using their relievers at this point of time. Now, if you are using salbutamol, you will continue to use extra salbutamol, which will not give you any anti-inflammatory benefit, ultimately leading to an acute exacerbation 5 days down the line. And you will have to prescribe oral steroids for that, which we don't want. Hence, instead of salbutamol, if you use the combination with an inhaled corticosteroid, that is formoterol budesonide, you are giving anti-inflammatory as well as bronchodilator therapy, and extra usage of puffs before there is an acute worsening will lead to abortion of that particular exacerbation. So you will start using extra formoterol budesonide at this stage, and instead of peaking, this exacerbation gets aborted, leading to recovery. And hence, you end up avoiding using systemic steroids, protecting the patient from worse side effects down the line. So the combination inhaler, formoterol budesonide, is not only a bronchodilator, it is anti-inflammatory, and hence it is better than a short-acting beta-2 like salbutamol. And this has been the landmark change in approach to therapy for asthma. So now there are no two inhalers. There is just one combination inhaler, which is the controller, and you can use that same controller inhaler multiple times at the times of worsening symptoms as the reliever as well. And this is what the guidelines in 2023 preach us, that there are two tracks available to us now. And I'm going to just focus on the important aspects of this. So the preferred approach is the SMART or the MART approach, which means maintenance and reliever therapy. So you can use ICS formoterol, and like I said, it could be budesonide, fluticasone, beclomethasone, or mometasone with formoterol as the controller, and you can increase the dose with increasing severity of asthma. And you can use a reliever, which is the same drug as and when needed. For mild asthmatics, you can even use SOS drugs. And for moderate to severe asthmatics, you need a fixed dose delivered every day, and as per need, you can give extra puffs. However, this approach cannot be practiced with salmeterol, like I said. So salmeterol fluticasone is an equally good product, but for that, you have to ensure that the patient is regularly taking salmeterol fluticasone. And for reliever, you can't use formoterol budesonide here because that will clash with salmeterol. And hence, as a reliever, you have to use salbutamol or salbutamol with beclomethasone. Now that again becomes two different inhalers and it confuses management. So we would not like to practice that approach. As far as possible, we need to focus on the single inhaler approach, that is maintenance and reliever therapy, or the MART approach. There are several non-pharmacological interventions as well, and I'm not going to highlight them, but all of you are well aware of these, and these are important to improving control of asthma. So just to revise what I just said, you need to check on the left-hand side about symptoms of your patients. So if there are twice or more frequent in a month, you can start with as needed SOS formoterol with budesonide. But if these symptoms are persistent, associated with nighttime awakenings or low lung functions, you need to be on regular formoterol budesonide. That is your controller, and you can use it on SOS basis as well. Remember, medium dosages of inhaled steroids are safe for long-term use. So remember these ranges. So if you are on budesonide, do not cross 800 micrograms. If you're on fluticasone, do not cross 500 micrograms per day. Higher dose of inhaled steroids being delivered over a prolonged period of time can be associated with certain side effects, particularly in the elderly. So these are the cutoffs we usually use for inhaled corticosteroids. What about your pet drug theophylline? There is not a lot of data, but there is definitely some anecdotal literature which says that when added to inhaled steroids, remember it is not your first drug of choice. When added to inhaled steroids, it might help you in certain groups of patients. So you can continue to use theophylline, but it should be the last drug, not the first drug to be added to the list. So our patient, remember, he was not doing well. So we shifted him from Aerocort or salbutamol beclomethasone to formoterol budesonide, around 800 micrograms per day. He was continued on his theophylline, and his Montelukast dose was 5 mg, which was inadequate for his weight. It was increased to 10 mg. So now that we have optimized the drugs and their dosage, the next is which would be the best device to use to optimize delivery. And Dr. Tushar Patel is going to speak on this in the next few minutes. So I won't highlight that. But remember, there are lots of devices available to use, and use the one which your patient is most comfortable. And always emphasize teaching them how to use the device when you prescribe the inhalers, because without education, without teaching the patient the device, the drug will never reach the requisite site. Hence, teaching the device to the patient is imperative to improving asthma management. Now, the next question is, how long do you continue treating this patient, and when can you step down? Like in hypertension and diabetes, you can never step down on the drugs once the blood pressure is achieved, unless and until the patient has side effects like hypotension or hypoglycemia. But in asthma, once the inflammation is under control, you have the luxury of stepping down. So once the patient achieves control, and remember what I talked to you about control, if your symptoms are good, if your lung functions are good, if there is no nighttime awakening, if there are no exacerbations, all that includes control, and you can decrease your inhaled corticosteroid dose by 20 to 50% at every 3-month interval. But remember, when decreasing dose, you have to remember that there are certain groups of patients who can get worse. These are patients with severe disease who might have had exacerbations in the last 2 months, if their inhaler technique is poor, if they are smoking, or if they are pregnant. Remember, these patients, it is preferable not to step down very fast. Whenever you step down, you always give your patients an asthma action plan. What is an asthma action plan? It is a simple plan. Like, for example, at Sparsh, at our center, we have this plan where we tell our patients that if you get fever, you can take a particular drug. If your breathlessness is increasing, you can increase the dose of inhaler. If it is very severe, you can take a course of systemic steroid. A simple plan which helps the patient tide over the emergency has to be given to every asthmatic patient so that he can handle his emergency at least when you are not available or when you are not accessible. So this is, in short, simplified asthma management. So you can start with formoterol budesonide, 1 puff twice a day or 2 puffs once daily, and then you can see whether he needs extra puffs or not. If the patient needs between 2 to 7 puffs per week, this is ideal. The patient is controlled and you can continue the same dose. But if he needs less than 2 reliever puffs, you can step down to step 1, which is SOS use. On the contrary, if he needs more than 7 puffs, you can step up the dose from 1 puff twice daily to 2 puffs twice daily. In case the patient doesn't achieve control, then we can move forward. So this is what we did for our patient. But in spite of doing all of that, his asthma did not improve. He was still missing several days of work. He was not able to exercise, and there was constant breathlessness. He also had symptoms of rhinitis and GERD. And although he was compliant on most days, but he was not taking his combination inhaler all the time, he was still not using a spacer, which we had specifically instructed. And that also affected the delivery of the drug. So if your patient continues to remain symptomatic in spite of a good dose, a properly delivery device, and adhering to therapy, what next? You need to constantly assess asthma control. And hence, when an asthmatic is not controlled, before increasing the dose or adding or piling on new drugs, first and foremost, go through this basic algorithm. First, reconfirm the asthma diagnosis. Why? Because there are several respiratory conditions which can mimic asthma, but they are not asthmatics and hence will not improve with treatment. Second, you need to do a spirometry in all your patients of asthma to confirm diagnosis. If a spirometry is not possible, even a simple peak flow meter can help you diagnose your conditions, and this is freely available with most of the pharmacies, and you can use it in your clinics in day-to-day practice, not only to identify and diagnose asthma, but also to monitor your patients with asthma. Second is, you need to confirm that the patient is adherent to the inhaler and always check his technique. Without looking at these two important aspects, never increase the dose of drugs, because these two things will hamper your treatment even after increasing the dose of drugs. Last but not the least, you need to focus on the triggers which the patient is exposed to and look at comorbid conditions. Why? Because treating these two, that is treatment of triggers, and there is a huge list of them, avoiding these triggers, as well as treating comorbidities, will go a long way in improving asthma control without even touching your asthma medication. So many times treatment of rhinitis or basically GERD, reflux, or anxiety will go a long way in improving asthma control, because these are the reasons why asthma is uncontrolled. So in our patient was not compliant, so we tried and ensured adherence. We started making him use the spacer. We optimized the dose of his drugs. We asked his father to stop smoking in his presence. We asked him to get rid of his pet, which could have been a reason for his worsening. We gave him a PPI for his GERD, and we also treated his rhinitis. Plus, he was instructed to lose weight. Now, in spite of all this, basically our patient still remained symptomatic, and he was hiked up to high dosages of inhaled steroids, and he started using intermittent systemic steroids, clearly showing that in spite of our best efforts, there will be some patients who will not improve. Now, in that kind of a situation, are there some reserve drugs which you can add to? Yes, this is a patient of severe asthma, and there are some reserve drugs. So when do we label a patient as severe asthma? It is a patient who has symptoms of uncontrolled asthma. And this patient, once you have clarified adherence, checked the techniques, avoided the triggers, and treated the comorbidities, and in spite of all this, the patient still remains symptomatic, that is the time to label a patient as severe asthma. So our patient actually had severe asthma, and hence we ended up trying out a few reserve therapies for this patient. Now, at this juncture, most of our patients end up using systemic steroids because it is extremely challenging to treat these patients with routine medication. But what I would like to highlight from this study, which came out from the UK, it included a study of 25,000 patients. And it included the side effects which we commonly see with systemic steroids when we use them for prolonged periods: osteoporosis, pneumonia, cardiovascular and cerebrovascular disease, diabetes, weight gain, and so on and so forth. But to our surprise, what this study clearly shows, that even if our patients end up using 4 to 9 short courses, a short course is 5 days of 30 to 40 milligrams of prednisolone. Even if they use in their entire life, the odds ratio of getting side effects is tremendous. So every short course of steroid can lead to significant side effects. And we sometimes are so oblivious to this fact that we keep on prescribing short courses of steroids. So please bear in mind that every time you prescribe a short course of steroid, it can have a cumulative effect down the line and lead to disastrous consequences. And hence, if your patient is not doing well on a highest dose of a combination inhaler, and in spite of proper adherence, proper technique, treatment of comorbidities, avoidance of triggers, please refer him to a specialist. And we have certain options for these groups of patients where we can put these patients on biologicals. These are the three common biologicals we have in our country: omalizumab, mepolizumab, and benralizumab. Our patient was started on mepolizumab, and he, in fact, improved over the next 6 months, and he started having a greater and a better quality of life once on the biologic. That was success. Last couple of slides. In the last 2 years, now we have access to long-acting inhaled steroids and long-acting, ultra-long-acting beta-2 agonists, because of which, instead of using twice daily inhalers, we have been able to cut down the use to once daily. So this helps us improve adherence, and you remember, adherence goes a long way in improving asthma control. So you can either practice the SMART approach, which means you take one inhaler, formoterol budesonide, start with say 2 to 4 puffs a day, and see how many extra reliever puffs the patient needs. And if the patient is improving with very few puffs required, you can step down. But if the patient requires extra puffs, you can step up on the dose. You can go up to a maximum of 1600 micrograms of budesonide. That is 12 puffs a day of the 100 microgram strength you can give without causing side effects. However, we in our day-to-day practice now have graduated to the ultra-long-acting ICS LABA combinations, where most of our patients are on bilanterol fluticasone or indecatrol mometasone. The benefit of this product is that you can use them once daily. However, these products cannot be used as maintenance and reliever. So with these products, you still need 2 inhalers, a separate reliever and a separate controller. And hence, this might be a choice of therapy for few patients. But your basic choice of therapy should be the MART approach, a single inhaler which treats your acute worsenings, and the same inhaler which is used for maintenance. Hence, I would say that we have come to simplifying asthma management to a great extent over the last decade, and I hope you can practice this when you go back to your clinics today. I thank you for a patient listening, and I'm open to questions.
Thank you, Dr. Harjit Dumra, for excellent presentation on a simplified management of asthma. We family physicians must have to keep us away from the disease of salmeterol in day-to-day practice, and we have to definitely use the formoterol with budesonide. You have really give the number of other hints for the family physician, and I request Dr. Darbar to again repeatedly arrange the lecture in the same fashion, and we may need work on also workshop for that, hand-on workshop. Thank you very much, sir. And question answer, I think we will take after the lecture of Dr. Tushar, because time is running fast, sir. Now, I'm going to introduce Dr. Tushar Patel, another stalwart from the field of pulmonary medicine. Dr. Tushar Patel graduated in the year 1995, obtained his MD chest degree in the year 2000. He was awarded FCCP, American College of the Chest Physician degree in the year 2008, and degree of FNCCP, a fellowship in National College and the chest physician in the year 2019. He was a successful teacher looking to his teaching career and a professional career. His work as consultant, pulmonologist, and critical care specialist at Sterling Hospital in Ahmedabad from 2001 to 2022. From December 2021 to till date, he is a professor and head of the department of tuberculosis and the chest diseases, GCS Medical College, Ahmedabad. He is a director and consultant pulmonologist at Sparsh Chest Disease Center from 2011 till date. There is a long list of awards and publications on the name of Dr. Tushar. What to be mentioned, only 1 and 2. Appreciation award by the government of Gujarat looking to his work and activity and contribution during the COVID pandemic. P.R. Trivedi Oration Award Trophy in the year 2019-20, Jigit Dalal Memorial Award. He has held various posts. He has held the various posts in the various association of tuberculosis, in the Chess Society, in the Indian Medical Association, and during COVID, he worked tremendously for the benefit of the society. And one more further is added in his crown of Dr. Tushar. Recently is elected as the president of a very prestigious Ahmedabad Medical Association. Sir, I heartily congratulate for you. With this very short introduction of our beloved Dr. Tushar, I request to start his lecture, Optimizing Drug Delivery, Choosing the Right Device in Obstructive Airway Diseases patient. Dr. Tushar, sir.
Thank you, Vinod Bhai, for kind words. And I also thanks to the Jaswant Darbar for giving me opportunity regarding this talk on obstructive airway disease to optimize drug delivery, choosing right device. Dr. Harjit say in his talk regarding all the management of asthma and obstructive airway disease, briefly all the aspect of drugs, pharmacological aspect of drugs is taken care nicely, but he says a proper device, if you not choosing a proper device for the management of the obstructive airway disease, you can not get good results or proper control of the disease. So next my talks regarding the inhalation of therapy proper, which type of device is using. In 2000 BC, people in South India burnt the dry leaf of the Dhatura plant to inhale the smoke for relief of the cough and breathlessness. During the colonization, the British colonization, at the time of also they are using asthma medication for asthma cigarette. In that also the Dhatura leaves used. 1926, a pressurized valve spray used for the insecticides. Insecticide with design, and after 3 decades later, valve from Meseberg valve used for into the perfume and head spray. 1940 dry powder inhaler used to deliver inhaled penicillin powder. In 1956, the 13-year-old American girl who is suffering asthma, instrumental to development of pressurized inhaler device. Her father is working a scientist in 3M laboratory in USA, built a first pressurized meter dose inhaler device in 1956. Why inhalation therapy used? Inhalation route is a much preferred in that over a oral route in treating obstructive airway disease such as asthma and COPD. Advantage of inhalation therapy is first and foremost targeted delivery. Inhalation directly effect on the lungs. Lungs faster onset of actions. Dr. Harjit saying the various reliever medicine within a second they are working in the faster onset of actions. Low dose intake, microgram. Instead of oral drug, we are taking a milligram, grams. We are taking this inhalation therapy, low dose intake, adequate and effective dose, micrograms. In minimal systemic exposures and side effect of these drugs. If we are taking a directly inhalation form, so only minimum systemic side effect, unlike the IV and oral drugs, they affect side effects on the liver, kidney, and all this things can be minimized by only this. We are using this inhaled therapy, only oropharyngeal candidiasis, this type of side effect is occurs. And avoidance of the hepatic fast pass of the metabolism. After in oral drugs, we are taking the oral form and then go to the stomach and then hepatic metabolites, and some systemic side effects is developed. Then effective and recommendation for all age groups from the infant to pediatric, infant to adult to the elderly people. All people can take the inhaled form of the therapy without going with our taking much help of the doctors and all these things and other people's. Comfortable and less painful. Inhalation therapy is a very cumbersome therapy, easily used ready to use, and like the injectable therapy or oral therapy, it's less painful and avoid the GI irritations and other pains. The advantage of this inhalation therapy, like other oral form of drugs, if we are taking oral form of drugs, and then GI irritation, GERDs, and also acidity, is this type of problem is not occur into the inhalation therapy. This is the advantage of inhalation therapy. Various guidelines recommend inhalation therapy. GINA guidelines strongly recommend for the inhalation therapy for the asthma. Also, GOLD guideline is also strongly recommend for the COPD patients. In Indian guideline, discourage the oral therapy and strongly recommendation for the inhalation therapy in management of obstructive airway disease. And patient of all age group, including children to the elderly as well as suffering from the obstructive airway disease, is offered inhalation therapy in all guidelines. This type of inhalation device is available. Dr. Like Harjit Patel, all the combination LABA, LAMA, all combination is available into the inhalation form of therapy in pressurized meter dose inhaler PMDIs, or add along with the PMDIs pressure, also handling chamber and mask. Then dry powder inhalers, unit dose, multi-dose, discrete with reservoir, breath actuated device, Synco breath now available. This breath actuated device and nebulizer, jet nebulizer, ultrasonic nebulizer, mesh nebulizer, and breath enhanced nebulizers. This form of inhalation device available. Which age group is preferred? Which type of condition? Which device is used? What device is used? Next in my talk, I tell you about all the advantage and disadvantage of various devices. Science behind the aerosol drug therapy. Mechanism of aerosol deposition and particle size is very important into the various drugs. Particle size is more than 5 microns. It is mostly deposited into the mouth and esophageal regions. No clinical effect. Absorption from the GI tract swallowed. This is oral form. This is the impact of large, more than 5 micron. My particle size is mostly effect on the upper airways. Then 1 to 5 is the ideal size of micron for the aerosol therapy. 1 to medium size of my aerosol therapy, mostly deposited into the upper and central airway. This is the upper airway and central airways. Mostly this segmentation is occur and deposited, and better clinical efficacy, clinical effect is very good, and subsequent absorption into the lungs is very effective. Less than 1 micron particle size is mostly goes into the peripheral small airways and into the alveoli. Some of the local clinical side effect, but mostly highly systemic absorption occur. So this is the mechanism of aerosol deposition and particle size of this airway disease inhalation therapy. Selection of right device for right patient is very important for the treatment of approach to the inhalation device is integral component in the management of disease of asthma and COPD. Tailoring, selecting of patient specific inhalation device, improve the patient satisfactions, also improve the patient adherence of the drugs, because this asthma patient and COPD patient is long time and long term requirement of this drugs is required for patient drug treatment satisfaction and adherence is very important. Offer better clinical control and improve the long-term outcome is very important for the selecting of right device for the right patients. First device is a PMDI meter dose inhalers, pressurized meter dose inhalers, most widely used, commonly used this device into the our countries. Small, convenient, compact, and independent of inspiratory product. This is a canisters. Then accurate. This is by cap, clamps, and valve here. Advantage and limitation of the device. Pressurized meter dose inhalers in generally mostly it is a advantage of is the portable, compact, multi-dose device available. Dose deliver around 100 to 200 dose devices available. Dose deliver in particular size, independent of inhalation maneuver, quick and easy to use, less expensive. most of the other inhalers suitable for emergency. It is also available into the reliever form, also into the controller form. Both drugs are available into the PMDIs. So very suitable if patient is any place, also doesn't require any battery or anything. It's simple take these drugs to the PMDIs, and available in most of the treatment, all reliever and this prevent medicines, both available in this form. Limitation, disadvantage of these drugs is coordination of the inspiration and evacuation is very necessary in this device, not suitable for young children and very elderly people. Without the use of pressure can be used with elderly patients. High oropharyngeal deposition in larger particles without use of pressures is this side effect, or most common side effect of this PMDIs. Dose counter is not available in all devices. As the remaining of the dose many elderly patient cannot be remembered around this patient. This device is empty or not, and dose is completed. And sometimes some patient is taking taking after emptying of this device, and then might be as exacerbation is occurs in this struggle. Propellant is required for the aerosolized form. Propellant is used into this pressurized metered dose inhalers. It's required. Some environmental problem is occurred due to the propellants and need to be shaken well before each inhalation patient. This because particular size is mostly available in the canister, need to be shaken before inhalations is proper combination is occurred of the drugs. To prime, if not used within a precise time of periods. Then another pressurized methodology with extra fine aerosols to less than 2 fine HFA particles used for in this PMDIs in extra fine aerosols is clinically lower dose drug used for compared with larger particle size and fewer side effect as compared to other particle size into the drugs. How to use metered dose inhalers, very important aspect. Dr. Harjit say, and in our practice also, if we not teach patient properly, then many patients are not use these devices properly and not asthma exacerbation without prescribe these inhalers, also not poor control of disease. Remove the cap and shake the inhaler. I teach you why shaking of the inhalers. Breathe out gently and deeply. Then place the mouthpiece between teeth and seal the lip, completely sealed. So many patients we see in our front of the patient to please take the inhalers. So many patients not taken inhaler properly and not close the mouth properly. So remaining amount of this drugs is out from the mouth. Acute canisters and beginning of inspirations and inhale slowly and deeply and hold the breath for 10 seconds. After taking deep inspiration, patient has to take, hold the breath for 10 seconds and then exhale slowly. This is a very important very important teaching aspect to take the inhalers properly device for any type of drugs. Then if patient is not possible, if patient is very infant or child patient or patient is elderly, then add this pressure device. Pressure device is very helpful to holding the medicine for few seconds. A patient immediate evacuation is not recorded. Patient elderly patient or a child patient not patient take properly breath to aerosolize these inhalers, taking the inhalers. In these conditions, pressure device is very helpful in this case. And aerosol moves to the particles pressure device to result a deposit large particle into the pressure and find and slowly moving into the plums. And increase the amount of drug reaching into the advantage of this pressure is mainly increase large amount of the drugs reach into the lower airways and also limit the amount of the particle deposited into the oral mouth and throat. So chances of the oropharyngeal the side effect of these drugs is very less into the pressure device. Advantage of PMDI with pacer, which reduce the oropharyngeal deposition, improve the pulmonary because the drug is going up to the lower airway. Also, these are helpful into the alternative if nebulizer is not available and electric lights is not there at that time conditions. If required, then MDI with pacer help into the also a time of exacerbation also. We should use who should use the patient who can't coordinate with PMDI device, children and elderly patient, and patient with high dose of ICS, patient who those required very large dose of Dr. Dumra says that around 800 micrograms or 1600 microgram. In these conditions, with patient large dose required in this condition because chances of this oropharyngeal candidiasis and less chances in this condition patient we can use. Acute case, if patient is patient with a nebulization, chances of the exacerbation is more exacerbation. At that time, this instrument can be used or normally. Inhalation technique, pressure MDI with pacer. Patient should breathe very slowly and deeply with this device in the device, and device contained univalvular. One side we use MDI, and another side at the mouthpiece single valve is there, univalvular. If we take breath slowly and deeply, the valve is open and drug is came out goes into the lungs. So one single breath with breath holding or 3 to 5 times tidal breath, normal tidal breathing patient has done, drug directly deposited into the lungs. Patient should preferably inhale immediately after the dose actuated into the spacer, and avoid multiple actuations into the multiple time actuation into the pressure spacer device. Choice of pressure device: child below 4 years, more than 4 years, MDI with spacers, and if child is less than 4 years, MDI spacer with face mask is also available. This is a breath actuated device, Synco breath, simple use for this paper. In this device, no actuation is required, and also no coordination is required during the inspirations. Another is a dry powder inhalers. Dry drug mixed with inactive expectorants. Powder blend with contain micronized particle of drug with larger carrier particle lactose. Lactose content particle. This is simple white powder available. Or lactose breath actuated patient inhalation cause deaggregations of the powders. Patient drugs particle was aggregate with the lactose, and then after breath actuation, deaggregation of the powder is occurring. Active particles of the lungs directly goes into the lung. Advantage of dry powder inhalers: there's a small, portable, breath actuated, less coordination is required, short treatment time, and available in most of the treatment, all LAMA or long acting drugs or short acting or reliever, all drugs form of DPI is available. But limitation of the DPI is moderate to high respiratory flow is required. Mostly it's used into the adult or young child more than 5 to 8 years, the age of the child or adult. This DPI can be used. Not suitable for young children in between below the 5 years. Not maybe suitable for in emergency conditions is not suitable. Partly sensitive into the humidity. Most of the time during the rainy seasons or any time, drugs is very thick, thin powder might be not come out into the through the inhalers to the into the lungs. So this is a disadvantage of this limitation of this dry powder inhaler. Need proper preparation and loading, achieve optimal available dose of inhalations. Dry powder is available single capsule dose base. Patient can use for single capsule. Their repeat medications can checking and capsule after use. Need to insert each dose of drug before use. and patient must be continue or repeat the inhalation until the capsule is empty, which can cause a dose variability. Then dry powder multi-unit offer the better protection from the environment compared with the single dose DPI. And also following dose preparation, actuation device need to keep horizontal but during taking inhalations, and patient must be not blow into the device before the inhalation, because if they had blow before the inhalations, then properly dose of the drugs is not coming to the inhalation form. DPI with multiple dose reservoir form, built-in mechanism meter each dose of upon the actuations and required a desiccations or inside the powder bed into the reservoir. These are type of inhaler. Unit dose, the dry powder inhaler, rotahaler commonly used, revolizer, loopyhaler, machaler, loopyhaler T. This one is a revolizers. This is a rotahaler, loopyhaler. This is a single unit dose, repeatedly change each single dose time, insert the capsules, and then take the patient take an inhalation of drugs. And multi-dose DPIs, discrete single pre-metered two available, Seephaler or autohaler. This is a Seephaler and this one is a auto AccuHaler. This and the reservoir dose of the drug, this DPI turbohaler. A unit dose, single capsule loaded each time. Multi-dose, multiple dose, no need to the load, but need some action of actuations. Then multi-dose DPI, discrete multi-haler, each dose individually packed, less sensitive to the moisture. This is a common side effect of single dose. This dry powder inhalers. Reservoir, all dose packed into the together, highly sensitive to the moistures. How to use? Take a rotahaler, insert the capsule into the rotacaps, rotate and then inhale. Revolizer, insert the capsule, search and inhaled. This is a multi-dose DPI. How to use a breath DPI? Patient DPI work on inspiratory effort generated by the patient. Breathing should be quick and forceful. Patient take a deep breath and hold it for 10 seconds and then deeply take deep breath to deposit all the drugs into the lungs. Advantage of another inhalation device is a nebulizers. It's mostly this nebulizer can be used during acute exacerbation of asthma and COPD when patient is critical or unconscious, when required medication is not available in inhaler format. Possibility disadvantage of this drug is possibility high dose toxicity due to the high dose of the compared to the inhalers. Nebulizers can also use high dose bronchodilator, also a antibiotic drug we can use onto the nebulized form. So many conditions. Also a supplementary oxygen along with the exacerbation patient can be used in the along with nebulization. High oral deposition, risk of transformation of airborne infection, main disadvantage. Nebulizer therapy, because proper not clean up the nebulizer circuit or any device, then chances of the airborne infection or infections chances of the is more into the nebulizer therapy. Nebulizer typically require longer time to deliver of the around 15 to 20 minutes. It's required to deposit to take drugs, and require regular maintenance of the device. One of the disadvantage. These are the nebulizers. Various drugs available, and most of the single dose available into the lungs, sometime in the bottle available various drugs, also antibiotic form of the tobramist, also broncho or mucolytic agent like mucinec is also available into the nebulized form. Which are the patients required various device? MDI with, if patient actuation is good and inhalation is coordination is proper and patient inspiratory flow is more than 30 ml, in this patient pressurized meter dose inhalers, rate actuated meter dose inhalers, dry powder inhalers and nebulizer, all form of the any device you can use for the this type of patient. If good equation and inhalation coordination, but patient inspiratory flow rate is less than 30 liter per minute, in condition, pressure metered dose inhaler or nebulizer can be used. And most of the patient with poor equation with inhalation coordinations, inspiratory flow rate is more than 30 ml per liter per minute. In this condition, PMDI or spacer, PMDI with spacer, breath acute device also can be used. DPI also used. Nebulizer can also use. But if inspiratory flow rate is less than 30 liter per minute, PMDI with pressure or nebulizer can be used. Most of the common poor equation and inhalation is included to children and elderly patients. These are the various drugs combination in asthma and COPD: levosalbutamol, beclomethasone, formoterol, beclomethasone, formoterol, budesonide, salmeterol, fluticasone, formoterol, fluticasone, formoterol, glycopyrronides, valentrol, fluticasone, various form of drugs in combinations into the inhalers, also dry powder inhalers, and some of the drug into the this respiratory is also available. What are the drug delivery method? Very young and old, very old and very young MDI with spacers, and very infant children MDI spacer with face mask. Elderly patient MDI with spacers. Young children more than 7 years DPI, rotahaler, or adult with education understood MDI alone, or adult with no coordination DPI with rotahaler. Clinical settings, MDI with spacer is also useful. In clinic or emergency nebulization, nebulizer can be used. Choice of individual trial and error may be did. Cost may be factor into the inhalation therapy. Summary to selecting most of the appropriate device: to consider patient age, skill, disease severity, availability, durability, cost, and easy of use of device. Physician and patient must be jointly decide on device to be which device can be used. Very many times patient also ask this is not suitable for me, like MDI not suitable for me. I take dry powder inhalers. Some of the patients sometimes may ask to us, I'm not suitable for dry powder inhaler, because due to the dry powder inhaler, many times oral ulcerations is occurs. This type of side effect is also occur to the patient. At that time, we can change of the MDI type of device. Nebulizer are most convenient drug during emergency and maintenance treatment at the home for patient who is unable to handle the inhaler device. Patient with COPD, choice of device should be based on rate of respiratory flow, cognitive functions, and manual detoxification. Same type of device should be used for treating acute and chronic symptoms can be possible. An inhaler with dose counter is preferable, because if the inhalers is empty or the dose is completed, and some of the elderly patients have difficulty after taking empty of the no drug is available in the inhalers, also they are taking, and chances of asthma exacerbation is or COPD exacerbation is more. Consult your family or caregiver before device prescriptions. Physicians must be trained properly, appropriately use of device. Thank you.
Thank you, Dr. Tushar Bhai. Very detailed, you explain what to use, at what time we have to use, what is best for the children, is best for the adult. And really, sir, we are thankful for. I think we require a lecture series on this basically. Dr. Darbar, sir, if you have any question, because I have no idea.
There are 2 or 3 questions which has come up. The first and foremost question is about the whenever we see in family, we see acute asthma episode. So at that time, how much meter, I mean, how long we have to use nebulizer or inhaler, and when we can call it as a status asthmaticus and refer to the hospital for admission?
This meter dose inhalers with spacer is mostly used in exacerbations, but if not available, then nebulizer is very preferable device for the acute exacerbation of asthmatic patient. After giving nebulization with a short reliever medication, like the salbutamol, and if not controlled, if up to 50 to 20 minutes we are giving, and in spite of this nebulization, or patient still on nebulization and worsening of the breathlessness and tachypnea, then you must refer to the patient for the hospitalizations.
And second thing, there are many stored in inhaler from simple this to cyclocyanide. Is there any difference in potency, or is there any specific choice to use in a specific condition?
No, any steroids is not specific, but yes, budesonide is giving a good results, budesonide fluticasone compared to the cyclocyanide.
Okay. And any role of anticholinergic inhaler in asthma?
Yes, anticholinergic like tiotropium is very useful device, and ipratropium is also useful, effective role into the asthma.
Okay, I think these are the 2 or 3 questions which has come up during lecture. So thank you, Dr. Tushar Bhai and Dr. Dumra Sahib, and thank you, Dr. Anbu Rajan also, and all the participants who have participated in this CME, second CME of the College of GP. Now the one more announcement, that our third CME in the August will be the second Thursday of August, that is 10th of August, 4 to 5, and the topic will be on pediatric, mostly pediatric diarrhea, or considering the season. We will take one more topic about the pediatric fever with focus or without focus. So third CME will be on pediatric update. Thank you all for listening, and thank you speakers. Thank you.
Thank you so much.
Dhiren, anything?